My name is Sinead Hellier, and I will be the chair for this webinar. CAN-SG is the Clinical Advisory Network on Sex and Gender, and we are a group of clinicians concerned about the use of gender ideology in healthcare and the management of people, in particular children, who present with gender dysphoria. We are on Twitter at can-sg.org and online at www.can-sg.org. Our topic for this evening's webinar is why legislation to ban so-called conversion therapy could harm people with gender-related distress. And I'm delighted to introduce to you our panel for tonight's topic. Our first speaker is Dr. Louise Irvine, a GP and co-chair of CAN-SG. She will be providing a background on the history of the bill to ban so-called conversion therapy, and will discuss some of the harms that are likely to arise. Our second speaker is Dr. Az Hakim, consultant psychiatrist and author of Detrans, When Transition is Not the Solution. He will discuss specialist psychotherapy for gender dysphoria and implications that the ban may have on treatment provision. Our final and third speaker will be Bob Withers, psychoanalyst, and we'll be discussing exploratory therapy, affirmative therapy, and the proposed so-called conversion therapy ban. So there are three wonderful speakers this evening. Just to provide some housekeeping on how this session will run before we start. The session will run for about 60 minutes. Each member of the panel will speak in turn for about 6 minutes. And at the end, there will be a final session for questions from viewers and the audience. There will be an opportunity for you to submit questions throughout the session using the Q&A box. It will not be viewable to you guys, but I will review the questions and read them out to the panel answer after everyone has spoken. Unless requested by the questioner, I will select one member of the panel to answer the question and then invite the other two to see if they've got anything else to add. I will try not to mention people's names when I ask the questions. This webinar will be recorded and it will be later on the YouTube channel of CAN-SG. So I would now welcome Dr. Louise Irvine to present her talk on the background of the history of the bill to ban so-called conversion therapy. Thank you, Louise.
Thank you, Sinead. Good evening, everyone. I'm going to give some background on the proposals to legislate to ban conversion practices for gender identity. Yesterday in the House of Commons, Kemi Badenoch, Minister for Women and Equalities, said the government would publish a draft bill to ban conversion practices for sexual orientation and gender identity. Such a ban was first promised by Theresa May in 2018 when she was Prime Minister, with the pledge repeated by Boris Johnson. The ban was laid out in 2 Queen's speeches, but dropped from the latest King's speech in November. In response to questions about the delay, the government said it was complex and it needed time to prepare the legislation to ensure any action was, quote, proportionate and effective and did not have unintended consequences. There are also currently 2 private members' conversion practices bills, one from Baroness Burt of Solihull in the Lords and one from Lloyd Russell Moyle MP in the Commons. The Labour Party has promised to bring in a conversion practices bill if it forms a government, if the present government does not do so. All such proposed legislation states as its aim to ban conversion practices for both sexual orientation and gender identity. The sexual orientation ban is uncontroversial. This refers to practices that most people agree are harmful and ineffectual, and which in UK medical and psychiatric practice have not happened for decades. Abusive and coercive practices are already illegal. The controversy relates to a ban on so-called gender identity conversion practices. This is because there are serious concerns such a ban could have unintended consequences. The Equality and Human Rights Commission said that any definition of conversion practices should capture harmful practices rather than legitimate and appropriate counselling, therapy and support. A government minister said, the legislation must not, through a lack of clarity, harm the growing number of children and young adults experiencing gender-related distress through inadvertently criminalizing or chilling legitimate conversations parents or clinicians have with children. We know those proposing the medical pathway view exploratory therapy as conversion therapy, because sometimes in the process of having their complex issues explored, a child or young person may decide they no longer want to embark on irreversible changes to their bodies. But that's not conversion, as it is not the deliberate aim of the therapist. Neutral exploratory therapy should not be lumped in with harmful conversion practices. Drafts of this legislation so far have used unclear language and failed to define terms such as transgender, conversion, or gender identity. You cannot legislate safely and effectively for what you cannot define. As James Esses of Thoughtful Therapists said, this ambiguous phrasing risks criminalizing basic therapeutic techniques, such as pausing for thought and reflection, exploring contributing factors, and exploring a range of options with a young person. Our concerns in CanSG match these concerns about the potential chilling effect on legitimate exploratory therapy, and that is what Az and Bob will go into more detail about tonight. There is evidence from other countries that have passed conversion practice laws that this fear is real. The state of Victoria in Australia has a conversion practices law that criminalizes parents and therapists who do not immediately affirm that the child or young person is in the wrong body and support gender affirmative medical and surgical interventions. Former Professor of Psychology at the University of Sydney, Dr. Diana Kenny, said there had been a steady flow of parents from Victoria contacting her for help since the legislation was passed. Dr. Kenny said, psychologists in Victoria are terrified of practicing non-affirming psychotherapy for children with gender dysphoria. Yesterday in Parliament, Kemi Badenoch explained the government's thinking on a conversion practices bill. She said, we're trying to find a legislative way forward that protects the interests of vulnerable young people rather than seeing them signposted, often prematurely, in a direction that is irreversibly harmful to them. She talked about an evidence-led approach. CanSG welcomes this. We believe people with gender distress should receive good quality, evidence-based support and treatment with a variety of therapeutic options. Treatment of children should be fully informed by the final report from the CAS review. CAS's interim report said gender clinics for children and young people had been overly affirmative, and there was a need for services where children could have psychological support rather than being offered puberty blockers routinely. It is clear the government does not want to bring in legislation that could cut across CAS's final recommendations. Talking of an evidence-led approach, it is striking that the research commissioned by the Government Equality Office from Coventry University found no evidence that gender identity conversion practices were happening in the UK or of any associated harm. That didn't stop the report's authors making the extreme and unevidenced claim that gender identity conversion practices cause mental illness and suicidality. We cannot base legislation on poor evidence, hyperbole, and scaremongering. Furthermore, there is strong evidence that the majority of children and young people referred to gender clinics will turn out to be gay once they go through puberty. Badenoch acknowledged this when she said there was a risk that LGBT children are being put on a medical pathway to irreversible physical changes, and that gender-affirming care could be considered a new form of conversion therapy. These are the serious questions faced by this or any future government that seeks to legislate on this issue. Let us hope there is thorough, evidence-based, pre-legislative scrutiny to ensure that we don't make bad laws that harm rather than help children and young people with gender dysphoria.
Thank you very much, Louise. That was really very interesting. Just a reminder to the audience, if you want to submit questions through via the Q&A box, please do. And then I'm very happy to welcome Dr. Az Hakim, who will discuss specialist therapy for gender dysphoria and how the proposed bill is likely to impact that. So welcome to Az.
Thank you, Sinead. So I'm Az Hakim, I'm a consultant psychiatrist, and for the past 23 years, I've been offering specialist psychotherapy for adults, so people over 17 presenting with gender dysphoria. I'm also the author of Detrans, When Transition is Not the Solution, which details all the work that I've done to date. For 12 years, I ran a specialist service from the Portman Clinic involving both individual and, importantly, group analytic therapy for these patients. The therapy was one of inquiry and neutral exploration. It was certainly not affirmative, for the purpose was to try and understand each other and oneself, not just to affirm something which the members of the group were there to explore and understand further themselves. Neither was the purpose of the therapy to prevent people from taking any course of action for their bodies. The therapy was given regardless of what any interventions people had or were planning to do. It was neither affirmation nor conversion. The binary black and white thinking, right, wrong, male, female, rigidity of the patient's mindsets was often manifest in the one-to-one setting in a very challenging way to therapy. But in an analytic group, which was entirely composed of members with various forms of trans, including those post-op regressors or detransitioners who had once idealized the prospect of transition, as some of the other members were now doing, alongside those who were probably more transvestite or fetishists. The mix allowed members to challenge each other from positions of similarity and difference, rather than just from the smarty pants therapist. The therapy was one of inquiry and neutral exploration. As I said, it certainly wasn't affirmative, and the emphasis was on exploration. Through the weekly group sessions, members' assumptions and notions of gender were examined by the group, and in time, these assumptions were often revised, having benefited from 8 fresh perspectives. The focus was on minds and not bodies. But a later survey I did after I finished the 12 years showed that less than 2% of the patients went on to pursue physical interventions of hormones or surgery, having realized that the conflict wasn't in their bodies, but was in their minds, and that they'd resolved it. I learned quite a lot of things from doing the work, and it was evident that there was quite a lot of confusion in the minds of people there. There was often confusion and conflation of notions of sex, gender, and sexuality, sex being biological sex, chromosomes and bodies, gender identity being this social construct that societies invent as to how we perceive maleness or femaleness to be, and sexuality, which is what people fancy, what or whom people fancy. Also, it became evident that the trans label was an umbrella term for lots of things. It included people who would formerly be referred to as transsexual, a term you don't hear anymore. It also included people who were formerly called transvestite. We definitely don't hear that term anymore. And people with fetishes such as autogynephilia. There've always been far more transvestites than transsexuals. And in my first book, I described 11 different subtypes of transvestite that I could recognize from the work. But all these people came thinking or believing that they were this thing called trans, and they were all put together. 26% of the patients I saw had been referred to me because they'd already had post-operative regret, and they may or may not have detransitioned. These were people who were never followed up by the gender clinics. They were invisible to data. And so when this fictional 1% regret rate is churned out, that's all it is, it's fiction. The regretters are not counted. The 1% is made up. There are far more than 1%. The other thing that was evident was there was many coexisting conditions. In my male patients who would formerly be called transsexual, so not the transvestites and the fetishists, but the transsexual ones, 100% of these would have been considered to be on the autistic spectrum. Often in the females, there was prominent trauma and a degree often of internalized lesbophobia, homophobia. Often, as Louise had mentioned, the real conversion therapy was the idea that some of these people had fled from their otherwise homosexual state in order to be a trans heterosexual. So the phrase transing the gay away is quite pertinent. Patients referred to the therapy as a lifeline. The post-operative regressors said they wished they'd been able to access that sort of group before they physically transitioned. If the therapy conversion bill goes through, such a therapy will be at risk of not being possible due to its non-affirmatory stance. Lobby groups are keen to label any therapist adopting a non-affirmatory model as transphobic or offering conversion therapy. I have and am frequently labelled a conversion therapist. A simple Google search of my name shows the extent of that. The most evil, dangerous, and transphobic psychiatrist in the world. Quite an accolade. None of this, of course, is from patients who've benefited from therapy with me, but by people who have never met me, but are keen to eradicate any non-affirmatory intervention. I've been the target of libelous newspaper articles by hack journalists who have on more than one occasion publicly campaigned for people to come forward who'd experienced such conversion in order to write articles of scandal. Although to date, the best they can come up with was someone who said I'd questioned why and how they came to understand themselves as trans. I've been professionally slandered by the I newspaper, the Pink Paper, and numerous online forums. Complaints have been made to various institutions where I've worked and to my professional body. Luckily, all of which came to nothing. Whilst I am personally resilient and have extensively published in the field with colleagues and professional bodies who are understanding and supportive of my work, other clinicians may be less fortunate and risk their professional lives being ruined simply for trying to provide a helpful psychological service to the patients. The result of such a climate is that I no longer offer psychotherapy for gender patients. It's too politically difficult. As my PA said, why don't you just see nice, depressed, anxious, PTSD, OCD, burnout, and ADHD patients without risk of being sued for doing your work? And of course, she's right. This is the death knell for psychological work for patients with gender dysphoria. We've recently seen an almost 8,000-fold increase in young girls identifying as trans, many of whom are simply gender non-conforming kids. And as Louise said, many are lesbians with internalized lesbophobia who've been groomed by those influencing them to believe that they should be trans. In my book, I explain why rapid onset gender dysphoria, or ROGD, is just a cool youth subculture and not a medical disorder. As I always say, if your child suddenly comes home from school stating that they're the wrong sex, you would hope that some clinician somewhere will ask them how they arrived at that conclusion. The therapy conversion bill risks intentionally or otherwise preventing such basic and clinically necessary questions even being asked. Thank you.
Thank you very much. That was really, really very interesting. Another quick reminder before we go on to Bob, just for the audience members to put any questions into the Q&A box. And our final speaker is Bob Withers, a psychoanalyst, and he will discuss exploratory therapy, affirmative therapy, and with regards to the proposed conversion therapy bill. So welcome to.
Thank you very much. And thanks to the other speakers. Like us, I think I'll just briefly talk about my route into this, which started in the early 1990s when I saw my first trans patient, who was actually a male to female and back to male detransitioner, who'd lived for 9 years as a woman, had had the surgery, taken the hormones, realized that it hadn't solved the problems that he was told it would solve, came to see me because he wanted to go back to living as a man. And he tried to talk about his experiences, but every time he did, he was hounded and harassed and trolled and bullied until in the end, as it like somebody who's left a cult, really. In the end, the only way that he could get the mob off him was to say that he'd made the whole story up, and then people left him alone. So that's what happens to people who try to speak out. But he begged me, really, before we finished our work, if I could, to speak out for him. And that's really what I've been doing. And since then, I've worked with other detransitioners who he had trouble identifying as male because he really felt that any male traits were to do with toxic masculinity, because he'd had very bad experiences of his own father and the men in his life. And the other detransitioners I've seen have been, for instance, as and Louise have said, young women who've identified first of all as lesbian and then found they get into trouble at school or whatever, and then miraculously they identify as trans. And young men as well, gay men who find it hard to accept their homosexuality, and also people who've been sexually traumatized. So some of the trans people are identifying as trans as ways of getting, escaping from these difficult experiences and thoughts and feelings. And I've been trying to advocate for working therapeutically before people make changes to their bodies that they could come to regret. And for that, like as I've been called transphobic and a practitioner of conversion therapy, hounded in social media. And if you Google my name, the first site that you come up to is one which does accuse me of those things. Trying to condense this into a brief talk and also to keep up with the events is really difficult, especially because, as Louise said, there was this fantastic discussion in the British Parliament yesterday, you know, which I just saw before the webinar, where Kemi Badenoch was absolutely brilliant, and it gave hope. It made me feel she really gets the issues, and she was answering people's questions in a respectful and informed way. And it made me proud to be British. It made me think we're leading the world on something here, because nobody else has really dared to question the orthodoxy. And if I have time, I'll talk about the way that a lot of this orthodoxy and the promotion of it is funded by drug companies, who are the people who clean up from this. In fact, I'll say this now, I was going to save it till the end, that these drugs have been used on children experimentally, and so they're actually used off-label. And the thing about a drug company using treatment off-label, according to my son, who knows about these things, he's worked in the civil service, approving medications and medical treatments for NHS use. If a drug is used off-label, it's not the pharmaceutical company that becomes liable for a compensation claim. It's the clinicians who have provided the treatment. So sadly, if these treatments become even more freely available, and in a minute I'm going to say why I think they will if this conversion therapy bill is passed, the people who become liable will be us, the taxpayer, who will be funding the compensation from the NHS for the people who've been harmed by these treatments, who, as said, aren't really recorded in the data. So a month ago, the United Kingdom Council for Psychotherapy, of which I'm a member, it's my registering body, made a brave statement. It recognized publicly for the first time any therapeutic organization that gender critical views are protected by law, and that gender critical therapists, that is people who question the gender ideology and who believe in the biological reality of physical sex, that those beliefs are not only protected by law, but the therapy associated with them tends to be exploratory therapy, the therapy that might explore why somebody identifies as trans and whether they can come to terms with the dislike or hatred of their body that may result from sexual trauma, internalized homophobia, and so on, by means which are less radical than invasive therapy. So this statement was made about a month ago, and I really welcome that. So two really good pieces of news to begin with. But 2 weeks after that, Baroness Burt, the Liberal peer, had a private member's bill topping the ballot in the House of Lords, which wanted to reinstate a ban on conversion therapy using the outmoded definition of conversion therapy defined in the Memorandum of Understanding. Now, the Memorandum of Understanding is a document which has been around for several years and has been signed up to by all the leading therapy and clinical organizations. And it states that any practice which prefers implicitly or explicitly one gender identity or sexual orientation over another is in fact a form of conversion therapy. So on that definition, if somebody had been traumatized, let's say like my first patient I talked about, traumatized by a violent father, came to hate his physical body, and I tried to work on that therapeutically with him, I could possibly be accused of practicing conversion therapy, because obviously if the trauma work is successful, he will no longer have to dissociate from his body and identify with the female part of his personality. He'll feel more at home in his body, and his gender identity would be aligned with his body. So that I could have been accused of converting his gender from female to male. Now, it might well be that a court of law would throw out an accusation of that, but as and I have said, we've been publicly accused of conversion therapy. So it's possible that we would end up having to defend ourselves in a court of law if Baroness Burke got her way. Incidentally, she's a Liberal peer, and the Liberal Party have been massively funded by Ferring Pharmaceuticals, who provide the puberty blockers for the NHS. Then, 2 days ago, Lloyd Russell Moyles, my own MP here down in Brighton, put a similar bill before the House of Commons, a private member's bill, and he came 5th. And he has a slightly broader definition of conversion therapy. He talks about the danger of converting somebody either from or to a particular trans identity. The trouble is, though, that if somebody comes along to therapy and you do anything other than confirm them as trans or as not trans, you could be accused of practicing conversion therapy, and you could end up in a court of law. Of course, no therapist would like that. And so therapists are probably not going to do exploratory therapy if this law, according to Russell Moyes or Baroness Burke, if it gets into law, or in fact, Keir Starmer and the Labour Party, if they get elected at the next election, they promise to bring in a similar bill. Kemi Badnack, as I say, was brilliant yesterday because she said that the real conversion therapy that's being practiced is the conversion of gay kids into trans kids, and she certainly would ban that, and she would bring a law about banning the affirmative therapists, the people who don't tackle a gay kids or a proto-gay kids internalized homophobia. They would be prone to be prosecuted. The only trouble with that, of course, is then nobody doing affirmative therapy would be able to practice, and the therapy profession would be paralyzed because depending on who gets into power, there's a danger of either affirmative or exploratory therapy being banned by law. And so again, no therapists would want to risk being prosecuted. And what's the only treatment on the scene still available? Yeah, you guessed it, it's medical treatment, isn't it? So once again, Big Pharma cleans up. Now, I could go on, but I suspect I'm outstaying my welcome. But I would just like to say, well, I'll say one more thing. I could say lots more things, but I just want to talk about an even further extension of the idea of a conversion therapy. And Sex Matters recently talked about not only the conversion therapy that Kemi Badnack is referring to, but a sort of slightly more subtle form of conversion therapy, which I'm going to try and describe here. So it's a little bit difficult to get your heads around it, but bear with me. Normally, if kids identify as trans, within about 80% of cases, by the time they've gone through puberty, they desist. That is the natural history of trans identification tends to end in desistance. However, research shows that if you affirm a person in their trans identity, they tend to stick with that identity and move on to medical treatment. So this is what Sex Matters is implying and what I'm spelling out. There's a form of conversion of somebody into a trans patient if you affirm their trans identity. That is, you take their presentation at face value and you fix them into a trans identity. You're converting the natural history of a cross-sex gender identification into a fixed trans identity. So that's a form of conversion into being trans. And it's slightly different from converting somebody from being gay into being trans. It's transing away the natural gender exploration of childhood. In other words, it's saying somebody says they're a man or they're a woman or they're a boy or a girl, you affirm them, they know better. You don't say, okay, get on with playing. Well, make up your mind about what sex roles you like, what games you play, how you feel about yourself, even who you identify with. But you don't need to fix it. You can let it run. But if you do affirm it, you do tend to fix it. And then I'm contending that you do this further form of conversion therapy. So just one final plea. I just want to say that I really don't believe that the court of law is a place to actually try and sort this out. The Kira Bell appeal was turned down in the end because the appeal court said that it should be clinicians, not the court of law, that decides whether a child has competence to decide on the effects of a treatment, and also clinically whether that treatment is necessary. Now, there's a long and painful debate about therapy for gender questioning young people and adults, which we need to have in the therapy profession. My own feeling is if that's hampered by people's fear of being criminalized, it'll stop that debate moving on from the British Parliament, which we saw so wonderfully debate this subject yesterday, and it'll actually stifle debate, and it'll stop the therapy profession coming to its senses and realizing that inadvertently it's been colluding with a massive medicalization of what really is a psychosocial problem. Thank you.
Bob, thank you. That was really very interesting. So that wraps up our 3 talks for this evening, and then we're going to go on to answering some of your questions. Before we start with questions, I just wanted to read out one statement from a viewer here who says, I share the fear that this work is so fraught that many therapists will just avoid working with clients with gender-related distress, and those clients will be left with only affirming non-therapy. I have myself felt like walking away from the client group at times for this reason, which I think sums up very much what has been discussed here. Before we go to the questions from the audience, I wonder whether or not I might be like to kick off with a question of my own, if that's okay. So one of the core demographic of children who now present with gender-related distress are those who've experienced some form of physical and or sexual abuse, and particularly most notably those in the care system. This has been highlighted by Cass. So what will be the impact of this bill on investigating child abuse for these very vulnerable children? And I wonder if we can go to Bob for that one.
Yeah. Can I also just share a bit of experience? You know, I teach on a number of psychotherapy courses, and I've lectured about you know, gender dysphoria and its treatment internationally, and I regularly get approached by therapists who say, look, oh, you're so brave, I could never do what you're doing. And I say, well, I'm old, I'm near the end of my career, it doesn't matter if I get, you know, complained about. But they regularly say that yes, they're really inhibited from practicing exploratory therapy for fear of being kicked out of their organizations, and with, you know, with good cause, because my colleague James Esses was chucked straight out of Metanoia, his training organization, just simply for saying biological sex is real. And we should take notice of that, and for expressing gender critical views and expressing his wish to safeguard children. So it's a real fear. But to get back to your question, Sinead, if I can remember it rightly, yeah, looked after children not only by definition have attachment traumas, and if you've got an attachment trauma, you're very anxious about keeping people close, and you tend to adopt an identity that makes you feel that you're going to get connected to people. It doesn't come so much from inside your body as from outside and looking at what the other person is wanting from you. So you're already sort of unanchored from your body. And if you do get sexually traumatized on top of that, then there's a real danger that you can end up hating the sex body that got you into this horrible experience that you belatedly realize is something which society disapproves of, which you may have very mixed feelings about. And so it is absolutely true, as you say, that working with trans-identified children who are in care who have been sexually traumatized would be one of the therapeutic practices that could be, you know, there could be a chilling effect on people trying to work in that way, because the result of that may well be that the child in question, or the young person who was a child who was abused, ends up not having to identify with a figure of the opposite sex, but actually being reconciled with their body, which carries the painful memories of the sexual trauma which they've been trying to forget about or that they've repressed. And that work, because it's converted the person's gender identity, could be characterized as conversion therapy. That's okay if it goes all right, but what if it goes wrong? What if the child runs off to another therapist and says, this guy's been trying to get me not to be trans. He said that I've been sexually abused. I think he's a pervert, you know, he's obsessed with sex. And then there's a complaint. that's the danger. And that's why therapists, like the therapists I've met, where I've been teaching, are very, very reluctant to get involved with this field. But it's another reason for welcoming the growing awareness of the difficulties, and the fact that people are willing to speak up and recognize this is a far from straightforward area. And there's lots of people who, with very little knowledge, wanting to rush in with all the solutions, are actually, in my opinion, making things far worse, or in danger of making things far worse. So thanks for the question, Sinead, and sorry for the long answer.
Oh, no, thank you. That's great. Louise or Az, do you have anything to add?
It's just that at the moment, when the trans thing comes up, it's a bit like the Joker card in a pack of cards. Nothing else gets looked at. So it just makes it very hard for any coexisting problems, whether it's trauma, autism, and anything, or abuse, or to be looked into, because everything is just glossed over, and it just becomes a gender thing, whereas the gender isn't really the solution. It isn't really the problem, sorry, and it's not the solution to the problem.
Thank you. Next question. One we've got is thanks, Louise, for such a clear background. So well done, Louise. Do you and the other presenters think that this is about being value-based, not just evidence-based? And if so, what are the values that the three of you are adhering to compared to those pushing for a single affirmative directive for all therapists? So if we can go to Louise first.
Thank you.
What makes you different?
I actually think that being evidence-based is a value. I think it's important that we don't go charging in, led by ideology, and doing dangerous things to people. There are lots and lots of examples in medicine and healthcare of this having happened before. For example, the lobotomy craze, which is worth reading about. Tens of thousands of people had lobotomies with no evidence base and no follow-up. And the person who invented it got the Nobel Prize. And people's lives were ruined by this. And then there's also the satanic ritual scare and various other child abuse, the memory, sorry, I've forgotten the name of it, the
false memory
syndrome, and various other things, which actually really led to harming families and children. And again, they were fads, but they just took off. And doctors and therapists and clinicians are not immune to this. We're all part of society. We're all influenced by it. And we have to be very careful that we step back and say, where's the evidence this is helpful? And where's the evidence about harm? And to me, that is a value that's really important. And the other value is, I mean, as a doctor, I think we've all got that moral, ethical value of first do no harm. We shouldn't be harming our patients. Now, sometimes a treatment might have some side effects, but overall the balance is that you want to benefit your patient. So that is the approach I would take. And I think finally, when it comes to actually surgery, I do find it incredibly difficult to imagine the values of a surgeon that takes a scalpel to a young girl's healthy breasts and cuts them off. I think as a doctor, I've always, I think we all do, we try to preserve as much as possible the body. Our bodies are great. Now, sometimes they let us down and they need help and things have to be done, but we're not going in there and altering healthy bodies because of some ideology. So I just think, to me, that just gives me the heebie-jeebies. I don't understand how anyone can do that. So.
Thank you, Louise.
I can say something about that as well. My late father-in-law was actually a really, really good bowel surgeon, but he got involved in transgender surgery as well. And I think he really thought that he was doing good. And it was only when I told him that I'd worked with my detransitioner that he was absolutely shocked. And I don't think he ever did it again, but I think these people think they're really helping people be their authentic selves. It's just they've got rather unsophisticated ways of thinking psychologically. And I wanted to say something else slightly tangential about values. I know I've been picking up Kenny Badenoch, but one of the good things she said today was that this debate is much bigger than left v right. And in this very panel, we've got a mix of people from all sides of the political spectrum. And I think it's great that we can get together. And I hope this isn't used as a political football. That's one of the few things that makes me a little bit anxious about speaking out. I don't want to be used by one side or the other in the furtherance of a general political agenda, which I'm not in agreement with. I find it, like a lot of people, really hard to have a proper political home anymore, because some of the people I really believe in and share values with don't share my values over really important issues like this one.
Thank you. Yep.
Am I allowed to say? I've had a pretty unique experience in that when my first job in medicine after qualifying as a doctor was as a very, very junior house officer in plastic surgery, and I used to help hold retractors and things whilst the surgeons were doing sex changes. So I saw it from the surgeon's perspective, and they were just being master craftsmen. You know, they were doing something they were good at. They weren't. Their job was not to think about the mind, because the psychiatrist and the gender clinic had done that. And then, as a psychiatrist, I've sat in on gender clinics and seen how they operate. I've sat in on GID, the child gender service at the Tavistock, for 2 years, and I saw what I thought was clinical nonsense going on, where there was no exploration. It was merely just affirmation. I had a conversation with one of the people that was quite high up in the clinic, and I said, why are you doing this? Why isn't what you're doing mad? And they're just going to grow up to be normal gay people happy about their gender. And his response was, is it any more mad than if they were to become gay? Which was the stance of the clinic at that point. And this was only 2003, you know, it was only 20 years ago. And so I've seen it from the surgeon's perspective, the gender clinic's perspective, and then luckily working at the Portman Clinic, which, although part of the Tavistock, is a very gender critical arm, and through the work with the patients, and unlike a gender clinic where you see someone initially for one session, and then you have follow-ups, which might be 20 minutes of tick box scoring, see them every 6 months for 2 years. I was seeing people for an hour to an hour and a half a week, and for up to 10 years for each patient. So, you know, I had more time with these people's minds than anybody clinically. And that's what informed my understanding of what this whole situation is. My own understanding was revised several times during the work to get to where it is now. And as Louise said, our aim is to first do no harm. As psychiatrists, we have lots of patients who believe that they have a solution for their problem. We have severely depressed people who believe they really should be dead. And our job isn't to affirm them and help them commit suicide. We have anorexics who really believe that they should be thinner, even though they're critically low weight. And we don't affirm that. But for some reason, the gender ideology has captured organizations and stopped us being psychiatrists, apart from the psychiatrists who, you know, think otherwise.
Thank you. I was just going to read out a couple of comments, which aren't particularly questions. There's a few about as is Thai, which we won't go into yet. There was one regarding the Liberal Democrats. Let me just see if I can find it again. From an anonymous viewer saying that he's generally supportive of the general thrust of all three speakers, but wanted to clarify that Ferring Pharmaceuticals donation to the Lib Dems is connected to Brexit, because the top guy is an ardent pro-European, and that was the only reason apparently. But I don't think the Lib Dems are going to be able to extricate themselves from the issue with the pharmaceutical funding and puberty blockers, etc., as far as I can see. The other point I wanted to read out was, can I strongly disagree that the false memory debate is analogous here? The experimentalists undermining therapists working with abuse survivors on grounds of evidence are a terrible role model to look to. I will say more on and this person will put more on the CAN SG website, as this is a particularly important distinction. So that's interesting. The quick question, and I'll ask do you think, do you sense any change in the Royal College of Psychiatrists' approach to gender now that they have a new president with less investigation in their shiny Stonewall Gold Award? So yes, are we likely to have a less partisan view?
No, the Royal College of Psychiatrists is entirely captured ideologically. And as I put in an answer to another question, those running the college are totally captured, and they have these ideological position statements. I don't know any psychiatrist who agrees with the affirmatory position statement of the college. We recently pleaded with the college to survey its members to find out what the members clinically thought about this area, and it refused to do so, probably because they're worried about what it will come up with. So I don't have any faith in the Royal College adopting anything near a sensible position on gender anytime soon.
Bob?
Yeah, can I just answer a question that I just saw on the chat from someone who was asking, you know, because I started this whole political thing and I've slagged off the Lib Dems, and I'm terribly sorry if I got that wrong. Obviously, there's huge money in big pharma. It's massive. But somebody asked, what did we think would happen if a Labour government got elected? And I'm sad to say that in its present form, it's behind the game. You know, it's running along with Lloyd Russell Moyes, who I did write to and invite to this webinar, but I'm sure he's not here. But they've got a lot of catching up to do. But there are people out there who are prepared to debate this really seriously and who are really much better informed than a lot of the people on soapboxes about it. So the optimistic side of me thinks that the climate may well change by the time the next general election has been run, and that maybe even the Labour Party will have caught up a bit. I hope so anyway.
Thank you, Bob.
Could I just say a little thing? I think Labour will, obviously they're using this now, it's a pre-election period, so they're going to use it, you know, as people have said, as a political football and try to score points. But if and when they're in power and they actually have to bring in legislation, they're going to face the same problems that the Conservatives have. You know, it is actually really almost impossible to legislate on this in a way that doesn't have unintended consequences and possible harm. And everybody who's looked at it knows that. So I would hope, being an optimist, that if and when Labour is in power and they look at this issue, they too will see that it's complex and requires subtlety and thought and evidence. Anyway, let's see.
Thank you, Louise. I mean, let's be honest, you know, Canada and, as you say, Victoria and Australia have brought in these laws, and they've not paid much attention. So we did have a question regarding what we thought how this would impact in the next if Labour get in as the next government. So I think you've sort of answered that. Just with regards to hoping that people will take a sensible approach, another comment, in Scotland, men are given very minimal sentences for rape conviction if they are below the age of 24. However, if you want to remove body parts, you can consent at 16. Not very logical. So yeah, this is where we are at the moment, unfortunately. So another quick question. Let's have a quick look. So trauma, including rape, needs proper, easily accessible support in each home and work community. Why haven't we got more complementary therapies easily available without people having to feel so low that they are desperate to start thinking of surgery for breast implants, plastic surgery, etc., to make themselves feel better? If I ask Louise, with your GP hat on.
Yes, I mean, the issue is that there's very poor psychological mental health services are desperately underfunded. You have to wait months. If I see a patient that says, you know, I'd like help now, they're going to have to wait 6 months before they get anything, if at all. Child and adolescent mental health services are dreadful. It's about most of our referrals, they are rejected because they don't meet a threshold, and even the ones that are accepted, they more or less have to be suicidal. Even they have a very long waiting time to actually be seen and get treatment. So in general, mental health services are poorly funded, and that's a huge issue. And so in the CAS review and the new service specification for gender clinics for children and young people says that, you know, the first line is of treatment is going to be therapy and psychological support and psychoeducation, all those things. The question that has to be asked is, who is going to provide that? Where will they get it? And why will they be waiting months to get that? And so I think there needs to be a massive injection of resources into this whole area starting now. And I hope if there's a Labour government, then it will also recognise that.
My concern is that when they say they're going to provide therapy, is not going to be the exploratory, oh, why do you think that? Why do you feel that? How do you? Not that thing that I've been talking about. It's going to be affirmation. And affirmative therapy or affirmation therapy is a misnomer. It's not therapy. There's nothing therapeutic about it. There's no questioning. Affirmation is grooming. If you have a child who believes that they're a cat and you go along with the notion that they're a cat, you're grooming the child into this belief system. It's not therapy. So affirmative therapy is a misnomer. And when they say there's going to be therapy and support, my concern is it going to be real useful clinical therapy, or is it just going to be this grooming affirmation?
The thing about, thanks, Az, the thing about the CAS report as well was it was talking about the importance of a holistic approach. And Az was talking about that before, you know, that you get this sort of, what's it called, an overshadowing where you simply focus on one issue or affirm.
Blinkered view.
Yeah, but was this a question also about complementary therapy, Sinead? Is that part of the question that you read out there? Or did I mishear you?
Yes, it was just effectively asking why is there not the support of complementary therapies for young people and patients in gender-related distress instead of just going straight to surgery and hormones, etc.
Yeah, and often people who, I mean, I used to be a complementary therapist, and it was very interesting because a lot of the people who couldn't be helped medically, really, but also didn't believe they had psychological issues because they weren't sort of reflecting and feeling things psychologically. They maybe felt them in their bodies, like people with gender dysphoria, often ended up with the complementary therapists, you know, so it was really quite interesting to work in that way because that's what got me into psychology and psychotherapy in the end, because I discovered that a lot of people's physical distress is actually emotional distress, disguised as bodily distress. But the gateway was very often, if you go and see a complementary therapist, you're not actually stigmatized by saying there's something wrong with my mind, but nor are you barking up the wrong tree and just trying to get some physical medical treatment. So I think there is a role for complementary therapy, actually. But of course, like the sort of extensive psychotherapy that isn't just solution focused or brief, it's private, it's in the private sector. So I mean, I work in a charity which is in the private sector. That's where I work because I can provide a service there, and I try at the clinic which I work in, you know, to make it affordable. But it's private medicine, and the same thing is true really of complementary therapy. And unfortunately, the NHS is strapped for cash, and it's very hard to think about expanding its provision. In fact, it's probably trying to cut back, I think. And with all the claims coming up from the detransitioners, it's going to be bankrupt even more, isn't it? Anyway, as what
what I was going to say was the question of why people going straight to physical solutions and not having any sort of therapy. If you go back to my autistic spectrum observation, one thing about which is especially in the males, absolutely in the males, so not the transvestites but the transsexual, the ones that believe that they're of opposite sex, the nature of the autistic mindset is a very black and white and right or wrong. And if they've come to some conclusion that this is what they need, then they're very hell-bent on getting it. And anything else is annoyingly, frustratingly not the right thing. And they'll clamor for what they believe to be the solution and the treatment, which is physically changing their body. And this is for young people and adults. And if they create enough noise and enough fuss and enough of a problem to the health service, and the health service says, fine, we'll give you what you want. And there's the fallacy of giving them what they want is what they need. And in psychiatry, we know that what you want and what you need is often very different. But that's the problem, because you have otherwise articulate, you know, sort of people who aren't obviously psychotic, who are saying this is what we need, give it to us. And by not giving it to us, you're denying us treatment. And the NHS doesn't want to be seen to be denying treatment. So that's why they tend to get there first.
Yeah, and the other thing about autism is it tends to coincide with the difficulty in symbolizing emotions. You know, it's called alexithymia, of course, and sounds like a bit of a technical term, but it really means that people don't recognize and have the words for their emotions. And so very often emotional distress is felt in the body, and the person who's experiencing that doesn't recognize straight away that the origin is psychosocial. So this question of why so many autistic people or people on the spectrum identify as trans is very much connected with what you were saying, Az, but also with this difficulty identifying a problem as being an emotional, psychological problem because of this difficulty in symbol formation.
Great, thank you for that. A question that came in quite early on. If I can put this to Bob again, if that's okay, because he's mentioned specifically in the question. Can you talk about boys and common threads among detransitioners, please? Root in and root out of those who do not have any internalized homophobia. So specifically the ones that don't have the internalized homophobia. And with regards to the trauma, what percentage have experienced some kind of trauma? Yeah.
Well, can I say that although I'm very interested and I've researched this topic, it forms a fairly small percentage of my practice because, you know, like ours, I don't want to get dragged into just working with trans people. It's very demanding and it's very stressful. So I can't talk from personal experience except about the people that I've seen. And the boys that I've seen, the ones who either identify as trans or are detransitioning, I think there's a crisis about masculinity in our culture. And I think it's very hard to find a way of being male that is socially acceptable, because masculinity is often associated with toxic masculinity, traits like violence and sexuality, which is coercive and abusive. I mean, the Me Too movement is great because it encourages women to speak up and to protect themselves. But a lot of the boys that I see end up being very frightened of any sexual response in themselves and feel themselves to be predators. And it's quite hard to identify healthily as male in this culture at the moment. So I think there's a crisis of masculinity. And it's not made any better by the fact that lots of fathers let their children down. You know, they may be very hands-on when their children are young, but if the marriage breaks up, it's often the father, in my experience, who goes off and starts a new family and doesn't have very much to do with the children anymore. Not all the time, but there's a lot of sort of fathers letting children down who then grow up not being able to positively identify with any male role models and therefore feeling bad about their own masculinity and their own male body. So that's one of the routes that I've come across with boys and young men in particular.
Well, I mean, what I've found is that because I keep harking back to the autism, but it's so important, is that there's a sense growing up of something not being quite right about them or not quite the same as other people. And it may be that the mild differences of communication or empathy or understanding, or it may not be completely clear to them what the difference between them and their peers are, but there's a sense of that they're not quite the same. And then from there, some steps are taken in there trying to work it out. And for whatever reason, for some of those people, it will be located in the hypothesis that it's because I'm the wrong sex. This is helped by being in classrooms where you're taught that about gender ideology. And one of my autistic trans patients said, well, at school now we're taught that you can choose what gender you're going to be. So I think I'm going to choose to be a woman because men are like this, and this, and women are like this. And he didn't feel that he fitted this stereotypical male thing for the reasons that Bob suggested. So I think I'm going to be female, as if it was like a discussion about university courses that he was choosing or something. The idea that you can choose your gender and change your gender if you don't quite fit in, and this very gender stereotyping teaching which comes with gender ideology, like men look like this, rather than encouraging children to be gender non-conforming, be whoever they want to be and how to express themselves. We're harking back to some very rigid gender stereotypes. So if you've got this recipe of ingredients of a male child on the spectrum who recognizes there's something different about them from other people, and then with other factors comes to the erroneous conclusion that it's because their sex is wrong, and then in their very autistic fixed way they go, okay, I need to pursue this. That's what you tend to see. And then afterwards, in terms of the detransition, the degree of autism seems to be protective. So if you're really more autistic, it seems to be more protective, because you don't get that maybe that's not quite right. But it's the ones who aren't that autistic. They were autistic enough to come to that conclusion, but then they had some sense of, maybe I'm not really a woman, because and be able to question whether they did make the right decision and whether people did perceive them as what they wanted to perceive. And that's when the regret comes in and the realization that the solution is a false solution. So that's what I've seen.
And I also add that the sort of black and white thinking you're describing in autism is also connected with a sense of certainty. And that's difficult, because if you think about the memorandum of understanding, it says that there's nothing wrong with exploring gender with somebody who is questioning their gender, but if somebody's certain about their gender, you should just affirm it. Unfortunately, that catches a lot of these autistic kids who are very black and white in their thinking and are very certain of who they are and what they are. And it is a challenge to work psychotherapeutically with autism, because there isn't much room for thought or reflection. And maybe there is a place for therapies which include a physical element, perhaps some of these complementary therapies which also work in a psychological as well as a physical way would be more useful. I don't know.
Yeah, I just, sorry, somebody said here, not all girls who want to be boys are autistic or lesbians, and I think that's important that we remember.
Absolutely. And I was specifically talking about biological males being autistic. The girls don't seem to be. The girls, it seems to be more trauma of various sorts, whether it's sexual trauma or other trauma, or the trauma of being. I had one woman who had the trauma of growing up in a particular socio-cultural ethnic environment where girls were treated in a certain way, which was the trauma in a family full of boys. So that was her trauma. Other people had more overt sexual trauma. So boys, yes, autism. Girls, less so. But there are other things. The other thing I wanted to answer was someone was talking about the children who this explosion of children, and the explanation is in the book. The explanation that I give is that about the subculture. What I mean is that post-war, we've always had youth subcultures, and it's always been music-based up until Gen Z. So up until Gen Z, who are the first generation to have grown up with social media, we've always had, the whole point of a youth subculture is it's bridging the gap between being a child, where the world is how your parents told it to be, and an adult where the world is how you've come to understand it. The middle bit is about being subversive and throwing things upside down and ripping things apart and trying to understand things for yourself. And historically, it's all been in music. So you had hippies, mods, punks, rockers, whatever it is. It was all music-based, goths. And then with Gen Z, with the social media, the function of music was irrelevant, because now your identity was in your social media profiles. Before, our identities were in our bands. So now with social media, it's just a subculture. So, you know, I talk about goth Mark 1, 2, 3, 4, and 5. I was goth Mark 1 and 2. But, you know, the last music-based goth was emo, which is Mark 4. And then Mark 5 is trans and non-binary. And if you look at these kids who are trans and non-binary, or you look at emos, or you look at me when I was a goth when I was 16, we all looked the same. We all had ridiculous hair, funny colors, and I still got some remnants. And, you know, and so they're just the same. But it's, you know, when, I always say, when Jenny turned up at school with massive hair and purple lipstick, we're going, oh, you look so cool. What are you? I'm a goth. We all became goths. Now the same looking person turns up at school and they say, what are you? I'm trans non-binary. Everyone becomes, it's not an epidemic of gender dysphoria. It's a social contagion of what's cool. But the problem is now we're misunderstanding it as a medical condition, rather than just, oh, they're just being a bit goth, just let them get on with it, they'll grow out of it.
Yeah.
Thank you for that.
Yes. I just wanted to thank you. I just wanted to add something about when you think about what you were saying about autism or black and white thinking. I actually think that also exists in the whole concept of social transitioning. Whereas we know that children can be very gender non-conforming. We've all known little boys who like to wear tutus and fairy wings, and mostly their mums just let them. And I bought my son a Little Mermaid because that's what he wanted to play with. And girls who want to play football have short hair, wear boys type clothes, and mostly parents just said, fine, that's okay. We didn't sort of impose on people the idea that you actually were the opposite sex. this is the main problem, I think, that's happening now with social transitioning, is this lie to children. We're lying to children that you can change sex, you can become the opposite sex. And, you know, I've even heard of young girls who've said, you know, when I become a man, can I father babies? They actually thought that's something they can do. So we must go back to embracing and championing and supporting gender nonconformity without saying it means you've actually literally changed sex. It's so important.
Yeah, thank you for that, Louise. We are coming, it's just slightly past our time, so I think we'll just try and squeeze in 2 more questions, if that's okay. Thank you very much for the questions that you've putting through, and we can't get through all of them, but they were really interesting. The last 2 I would like to go to just about sort of help. One says, what can I do to persuade parents who are on board and affirming their autistic children with ROGD, so rapid onset gender dysphoria, about the harms of affirming and medicalising? So whichever of the panel would like to go with that.
I think just read my book. I mean, just give them my book and it'll debunk everything that has formed their captured understanding.
But also put them into one of your groups, Ayaz, because I think there's nothing like people actually realizing what the reality of a gender transition is to make them think twice about it, because the whole thing is just so romanticized. And I'm sure that's why your groups work, because...
Yeah, but I don't do them anymore, so there isn't a group.
Oh, well, that's a shame, but somebody should take it up because it's a brilliant model. And some people I've heard say it shouldn't be applied to children. Well, why not? I mean, you know, by all means, they have these people going around to the schools, and Transgender Trend is one of the people that points this out, putting forward sort of gender ideology. You know, a trusted adult comes and talks about, you know, how wonderful it is to be trans and how liberating and rainbow-like it all is, and you've got your gingerbread and your, you know, et cetera, but they're not exposed to the reality of the people who regret. And maybe chance that was the first person I saw, but once you see it, you can't close your eyes to it. It really, we've got to be careful. We do have to be careful not to sort of miss the point that lots of people do grow up feeling really, really uncomfortable with their bodies, and they do need help to try and come to terms with that. It isn't just a fad, you know. Sometimes there's a real issue behind it which needs addressing.
But not like the people who believe they should be partially limbed and get real limbs taken off. Well,
they obviously feel partially emotionally present. There must be an emotional issue there, mustn't there?
Yeah, absolutely.
Yeah, we would not cut their limbs off. We would try and address the emotional issue. Just like if somebody comes to me as a therapist and said, I feel suicidal, I don't say, okay, so you're feeling suicidal, that's fine. How do you want to do it? You know. But
the case of the person in this country who did manage to get limbs chopped off because they identified as a partially limbed person, it was signed off by the same person who worked in the gender clinic. It's the same thing, chopping healthy bits off because you believe you should. And that, you know, that famous case of that awful case in America that went around social media where the person believed that she should have been born blind, so she got her psychologist to put bleach in her eyes to blind her so she could be the blind person that she wants to be. I mean, it's just colluding. This affirmatory colluding is terrifying.
Well, it just shows, doesn't it, that we are a society which tends to concretize problems, and we do very badly collectively about thinking psychologically, thinking symbolically, thinking emotionally and socially. We tend to look for physical solutions, and we don't tend to see the importance of the psyche. And this is part of the trap. I mean, the same thing with all the medicines sold for mental health conditions, you know, the DSM, which is the Diagnostic and Statistical Manual for Mental Health, you know, you have to have a label in there, a diagnosis, to get your payment from the American drug industry, from the insurance claims. And basically, once you get your diagnosis, you're sold some sort of a drug. You know, it's a physical solution for what actually is something without a physical cause. All right, some serious depression gets helped by antidepressants.
Myself again, and then we'll get going.
But a lot of evidence seems to suggest that for most people who are depressed, antidepressants don't do any better than placebos. So we're selling it. It's a huge pharmaceutical industry which has set itself up on psychological suffering, and I don't think it's got a really sound clinical base. Most of it just doesn't have a sound clinical base. And this is just part of that general cultural diminishment of the importance of the psyche.
And I would say that I would draw people's attention to a very interesting article on our website called Lessons from the Wrong Side of History by Professor Sally Baxendale that talks about just that, about the tendency to use physical treatments to deal with social and psychological problems. And she goes right back in history and she describes how, I think it was, it was either the 19th century or early 20th century, when some people who had a form of epilepsy where one of their limbs moved involuntarily, and they just had the limb amputated, the arm amputated, because that was going to solve the problem. You know, how, you know, in a way we think we're beyond that now, but we're not really, are we?
Not very. No.
One last question before we finish off, if that's okay. From a fellow clinician, how do you deal with the distress of clients who are told you're transphobic? Sorry, how do you deal with the distress of clients when they tell you that you're transphobic? I work in an exploratory way with my clients, but fear speaking out publicly for the harms I see in the affirming approach, the fear that my clients feeling harmed by what they might experience as a betrayal.
I think I answered in one of the other things, is that I think, you know, we as clinicians, we have a strong ethical duty to do what we think is right, and as Louis said, to first do no harm. And as psychiatrists, we're used to getting called all sorts of things throughout our career. You know, if you don't want to be called horrible things, don't become a psychiatrist. So we're used to that. I think it's about you know, sticking with what you believe to be right based on clinical evidence and observation, and that's all I can say.
I think there's some very complex and important stuff behind all of this, because patients do often accuse therapists of transphobia, and it's very hard to, you know, to navigate a path between, on the one hand, colluding with something which the patient presents you with and not exploring it, and on the other hand, going in too hard and creating a backlash. But very often, you know, like my first patient that I talked about, he found it very difficult to integrate his anger because of his father. So patients who find it hard to integrate their anger, they often, it may be that in the therapeutic relationship, it may be therapeutic for some hostility to come up and be re-experienced in the here and now with the therapist, and for that to be all right. Because often in the family of origin, there is a kind of insecure attachment which makes the person feel unsafe to express aggression in a contained, safe and constructive way. And in that sense, those people sometimes turn the aggression in on their body, which they then attack by removing healthy body parts. So if you can get it into the room between you and the patient, and also if you can acknowledge what Winnicott called the hatred in the countertransference, such as the hatred that the patient, that you feel towards the patient when they accuse you of being transphobic, then you're in business. Then you can actually work with these really difficult emotions, which may lie behind the discomfort in the body and the wish to transition and the attack on the physical body. It's not easy, though.
Thank you. That was really interesting. Can I just ask if any of you three want to just sort of a 30-second summation before we end the session?
I think it was really good that all this issue is really discussed yesterday in Parliament. I think it's the beginning of a big change. Things are coming out in the open. I think it was good that, I think as Bob said, Kemi Badenoch said, it's not a right or left issue. And she actually appealed that people across the House could work together to try to bring about good legislation that would help people and not harm people. I think that is, and she also talked about an evidence-based approach. And I think if we stay with that and we try to have compassionate and rational evidence-based discussion, we're coming from a place of really caring about people. We don't want to harm people, and we want people to be okay. That's our job as clinicians. So, you know, I do hope that we can sort of depoliticize this to some extent.
I mean, my thoughts were, as I said, I've been doing this for 23 years, and up until about 5 years ago, I felt like I was the little boy in the Emperor's New Clothes and the only person saying that the Emperor was naked. I thought I was the only gender critical person on the planet. And then I joined Twitter and realized that there's quite a lot of gender critical people. And the fact that we're now a group, a big group of clinicians in CanSG doing something like this is great, because, when I was doing this 20 years ago, my colleagues were going, what on earth are you specializing in this for? What are you going on about? Why are you interested in this? What's the point? And I was thinking, because there's this massive unmet need and no one's thinking about this. And everyone thought I was mad for pursuing something that was so esoteric. But so I'm glad it's gone from no one thinking or talking about it to people being concerned, thinking and talking about it, which can only be good.
Yeah, it's certainly good that this is now part of a public discussion, because that gives us a feeling of, that it's all right to speak out. We're not quite so isolated. It is a bit like coming out, isn't it? It's coming out as gender critical. We've been isolated for quite a long while. And as it becomes more socially acceptable, I think there'll be respect for a gender critical position rather. And I think even, the person who was asking questions earlier about the effect on the therapeutic relationship of coming out publicly as gender critical, I think once it gets more acceptable in a general sense, then it'll be easier with our patients as well, because they won't just see us as trying to thwart them and stop them from being their true selves. They'll see that we are genuinely concerned, and we have a valid perspective which is worth respecting. And all credit to the people who blazed trails before, like Maya Forstater, for actually getting the gender critical position respected in law. She's done some huge favor. So thanks to everybody that's been involved with this. It's been a real collective effort, and I'm sure we've all done our bit. And it's great to see it finally moving, beginning to seem to move, although there are these other reactionary forces, but hopefully we can talk to them too.
So that's the end of our webinar today. I would like to thank the audience, over 100 to 115 people viewing live this evening. So that's fantastic. Thank you very much for taking the time to listen to our panel tonight. Again, many, many thanks to Dr. Louise Irvine, to Dr. Azhar Hakim, and to Bob Withers. Your contributions have been very, very informative. Just as a reminder, the webinar will be put up on YouTube, and it will also be put up on our website, which is, if I remember again, www.can-sg.org, and also on Twitter, which is @can-sg.org. So please follow us if you can. And thank you very much.